Hi everybody, this is Dr. Ihab Abdurrahman Ihab Tarawa, consultant of acute care medicine at Soba University Hospital, professor of medicine, University of Khartoum, dean of Sama Institute of Health. We are still doing our sessions in basic emergency care course. We discussed the ABCD approach. In this talk, we're going to discuss difficulty in breathing. After we finish the primary survey, the ABCD approach, then we move to secondary survey. We're going to do detailed assessment. The objectives are to recognize the signs of difficulty in breathing, list the high risk causes of difficulty in breathing, perform critical skills for high risk causes of difficulty in breathing. In order to assess and manage and stabilize patient with difficulty in breathing, you need certain skills. Airway maneuver, head tilt, chin lift. You need to know how to insert oropharyngeal and nasopharyngeal and laryngeal mask airway. Maneuver for choking, Heimlich maneuver. Oxygen administration, how to use different oxygen device, and how to use back valve mask ventilation, needle decompression for tension pneumothorax, three-sided dressing for sucking chest wound. I'm gonna put link on the comment section to important educational videos that can show you how to do this procedure, and hopefully in the future if we can arrange on hand-on session. It depends on the resources and circumstances. Let us proceed. Always whenever you have an acutely ill patient or seriously injured, consider to start with ABCDE approach. Always start with the ABCD approach and treat life-threatening condition. Whenever you find the problem, fix it. If it's an airway, fix it before you move to breathing. And you fix breathing before you move to circulation. After you do the quick primary survey, then you take history and we go through the steps of sample history. And after that, you do secondary detailed examination so as to find clues about the most likely cause, or even if you miss something in the primary survey, this is a chance that you can figure it out and then you start the treatment. In sample history, we're going to ask about S for symptom and sign, for allergy, for medication, past medical history, last time the patient has taken anything orally, and even surrounding the circumstances. Sign and symptom ask, when did the symptom start? Was the onset sudden or progressive? Do these symptoms come and go? And when they come, for how long they last? Uh, did the symptom change, the pattern of the symptom change over time? Is it getting heavier or lighter? And if there is any relieving, intervention or medication or treatment, and if there is any episode of similar, like some patient with asthma, if they have intubated, this is can tell you that this is high risk patient and you need to take him seriously. Sudden onset of shortness of breath, always think about a foreign body in the airway, swelling of the airway as in allergy and anaphylaxis, trauma, always consider trauma to the airway, to the lung, to the chest wall, and inhalation of toxic agent. Sudden cardiac problems, those with acute heart attack can have acute pulmonary edema. Arrhythmia and acute exacerbation of valvular disease can precipitate acute pulmonary edema. Rapid onset, rapid and deep breathing, what we call cosmal breathing, can happen because of acidosis. That can be due to diabetic ketoacidosis, poisoning, and rapid shallow breathing can happen also with anxiety. Slower onset shortness of breath, consider infection. It can happen over hours and days. Accumulation of fluid in the lung, as in chronic heart failure, patient with tuberculosis, they can have pneumonitis, or tuberculosis can have pneumonitis or pleural effusion. Heart failure, it lead to pulmonary edema. Pericardial fluid collection, as in pericardial tamponade, which is serious. And short of that, it can happen also with TB and kidney injury, kidney disease, chronic kidney disease. Patient with cancer can have accumulation of fluid in the pleural sac, in the pericardium. And also, if the tumor mass is very high, it can replace the lung tissues. Disease affecting the muscle and chest wall, as in Guillain-Barré and myasthenia gravis and dystrophies. Don't forget asthma and COPD. Ask the patient if was there anything that trigger the difficulty in breathing, what make it better or worse. Exposure to certain medication can precipitate allergies and anaphylaxis. Inhalation of gas and chemical, or exposure to fire, it can lead to airway swelling. Exposure to pesticide, it can lead to accumulation of fluid in the lung or muscle weakness. If the patient have orthopnea, he cannot lie flat, you can consider pulmonary edema. Ask if there any tongue or lip swelling or change in the voice. This can point to allergic reaction and anaphylaxis, and you have to watch this patient carefully because they can progress quickly into complete airway obstruction. Listen, are there any abnormal sounds? Do you hear stridor, high pitch, squeaking sound during inhalation, which reflect upper airway blockage, wheezes, high pitch sounds during exhalation? It reflects to lower airway narrowing in spasms. This happens in COPD, in asthma, sometimes with severe heart failure, in allergic reaction. Gargling, slow pitch bubbling due to excessive secretion and fluid in the airway. Ask, is there any pain associated with difficulty in breathing? If the patient has chest pain, consider myocardial infarction, heart attack. Patient with pneumothorax can present with pain in one side of the lung. Pneumonia can present with pleuritic chest pain. Trauma also due to trauma to the ribs, to the muscles, and the lung can present with pain. Pleuritic chest pain, consider pneumonia, and consider pulmonary infarction due to pulmonary embolism. Check if there is fever, if there is cough. Cough can happen with infection, but also can happen with pulmonary edema, with pneumonia, and presence of wheezes suggests asthma and COPD. Look for leg swelling, and edema in both legs can happen with generalized edema and with heart failure. Swelling and pain in one leg can, especially for those who have been immobilized because of recent surgery or travel, can lead to pulmonary DVT and pulmonary embolism. Pregnancy is a high risk factor for DVT and PE. And also, pregnant lady can have pregnancy-induced hypertension that can lead to heart failure. Medication, if this episode is manifested by taking certain drugs, or can point to allergic reaction. Recent insect bite also can precipitate anaphylaxis. Severe allergic reaction can cause airway swelling, difficulty in breathing. People can have allergic reaction to food, plant, medication, or insect bite. Ask currently if the patient currently taking any medication, new medication, or change in those can point to allergic reaction. Accidental overdose can precipitate symptom. It can trigger asthma. It can trigger heart block, and some medication can trigger arrhythmias. Past medical history can give us a clue. Patient known to have asthma and COPD can present with acute exacerbation and difficulty in breathing. Those with chronic heart disease, cardiomyopathy, and kidney disease can present with fluid overload and pulmonary edema. Heart attack can precipitate acute pulmonary edema. Those with cancer, tuberculosis, or kidney disease can present with pericardial effusion, pleural effusion. History of smoking can point to COPD and asthma, and also it can lead to lung cancer, and also is a risk factor for coronary artery disease that can lead to heart attack. Diabetic can present with acute infection and pneumonia, and they can present with diabetic ketoacidosis. HIV, patient with HIV at risk of infection, and also HIV is a risk factor for atherosclerotic heart disease and can lead to heart attack. Also ask the last oral intake. When did the patient last eat or drink? Full stomach put patient at risk for vomiting and aspiration, especially when you want to do procedure. You want to make sure when was the last time he had an oral intake. And ask about the event surrounding the illness. What was the person doing when he experienced difficulty in breathing? If during eating, it can point to choking. If he was exposed to fire and burn, it can tell about airway injury because of fire and burn during exercise. Also, it can point to exacerbation of asthma and heart attack. Was the patient found near water? Consider drowning, inhalation of water. If person is found near water, even a small amount of inhaled water can cause serious lung damage. Regarding events surrounding the illness, has there been any exposure to pesticide or inhaled chemical? Inhaled chemical and fire can injure the airway, and in fire you can see sign in the face. Pesticide can lead to pulmonary edema, and also it can lead to respiratory muscle weakness. This about sample history. We're going to continue in another talk about what you're going to see in finding. Always remember to do ABCD approach. When you find a problem, fix it, and then move to the second step. After you do the primary survey, then you move to the secondary survey, take sample history and detailed examination. Thank you. See you in the next session.